This is Sami Sahu, tutor, Department of Biochemistry, Sri Lakshmi Narayana Medical College, Puducherry. And today topic is metabolism of phenylalanine and tyrosine. So the objectives of metabolism of phenylalanine and tyrosine and the disorder associated with defective metabolism and the special product which are derived from phenylalanine and tyrosine. So what are the characteristics of phenylalanine and tyrosine? Let me see one by one. Both are aromatic amino acids. So phenylalanine is an essential amino acid, where tyrosine is a non-essential amino acid because it can be synthesized from phenylalanine, which yield both glucogenic and ketogenic as an end product. So they form certain special products. First of all, how they are converting into glucogenic and ketogenic. So phenylalanine get converted into glucogenic as fumarate and ketogenic as acetoacetate, where phenylalanine get converted into tyrosine with the help of phenylalanine hydroxylase. So another reaction will be taking place from tetrahydrobiopterin to dihydrobiopterin. So this can be rebacked with dihydrobiopterin reductase from dihydrobiopterin to tetrahydrobiopterin, and here where NADPH is converted to NADP. So tyrosine, let me see the metabolic pathway where tyrosine on transaminase with the help of PLP, it get converted into hydroxyphenylpyruvate. So coenzyme as a PLP. So this hydroxyphenylpyruvate on hydroxylase enzyme with the help of hydroxylase enzyme with vitamin C and copper, it gets converted to homogeneous state. It gets converted into homogeneous state. This homogeneous state oxidase will convert this into malonyl acetoacetate, whereas this malonyl acetoacetate get isomerized to form fumarate acetoacetate with the help of glutathione, where with the help of hydroxylase, where the fumarate acetoacetate get converted into fumarate and acetoacetate. This acetoacetate with the help of ketothiolase, it get converted into acetate and acetyl CoA. So this is the overview of the metabolic pathway. Here I have shown here that tyrosine get converted into hydroxyphenylpyruvate with the help of transaminase enzyme along with PLP as a cofactor, where keto amino acid is converted into alpha keto amino acid is converted into, where hydroxyphenylpyruvate get converted into homogeneous with the help of hydroxylase enzyme with the help of vitamin C and copper, where homogeneous will convert it into malonyl acetoacetate here with the help of homogeneous oxidase. This malonyl acetoacetate will convert it into fumarate acetoacetate with the help of isomerase in the process of glutathione, where fumarate acetoacetate get converted into acetoacetate plus fumarate with the help of hydroxylase enzyme, where this acetoacetate get converted into acetate plus acetyl CoA with the help of beta ketothiolase. This is the overview of the metabolic pathway, where the phenylalanine and tyrosine get converted into glucogenic and ketogenic product, where glucogenic product is fumarate, where ketogenic product is acetoacetate. So let's see what are the disorders associated with phenylalanine and tyrosine metabolism. These are the phenylketonuria, tyrosimia, alkaptonuria, and albinism. Phenylketonuria, tyrosimia, alkaptonuria, and albinism. This is the overview where the enzymes defects takes place in the each product. Let's see. First, phenylketonuria the phenylketonuria is the disorder where phenyl hydroxylase enzyme is absent. So this here it get blocked. So the phenylalanine cannot converted into tyrosine. So because of phenyl hydroxylase enzyme will be not there. Next, tyrosimia type 1, where hydroxylase enzyme will be not there, where fumarate acetoacetate will be remains there and it cannot convert it into acetoacetate and fumarate. So this will be called as tyrosimia type 1. So tyrosine type 2, it has a enzyme defect as transaminase enzyme, where the tyrosine enzyme the tyrosine substance cannot be converted into hydroxyphenylpyruvate, whereas transaminase enzyme is defect. So it is called as tyrosemia type 2. And then tyrosemia type 3, which is present in neonatal, where hydroxylase enzyme will be absent. So where like phenylpyruvate hydroxylase enzyme will be absent. So homogenesis won't be takes place. Then next one is alkaptonuria. Alkaptonuria, which has enzyme defect of homogeneous oxidase. So the accumulation of homogeneous will be there because of oxidase enzyme will be not there. So it cannot get converted into malloacetoacetate. Let's see one by one in briefly. So types of phenylketonuria and their defects. We have three types, where hyperphenylanemia type 1, the defect is phenylalanine hydroxylase enzyme, where hyperphenylanemia type 2 and 3 is dihydrobiopterin reductase, and the hyperphenylanemia type 4 and 5, which has dihydrobiopterin synthase. So the characteristics of phenylketonuria are this phenylketonuria, it's an aromatic amino acid defect, where 1 in 10,000 children will have, births will have this defect. So where the phenylalanine hydroxylase enzyme will be absent, therefore the phenylalanine will be remains there, and it can take a alternate pathway. It can take a alternate pathway by which it converted into toxic metabolites like phenyl acetate, phenyl pyruvate, phenyl lactate, phenyl lactyl glutamine, phenyl acetyl glutamine, and phenyl ethylamine, where accumulates in the tissue, plasma, and urine. So the neurological symptoms will be delayed milestone, brain damage, mentally retarded, microcephaly, seizures, hyperactivity, and myelination of the nerve is defective. They have mousy odor due to phenyl lactate will be present in the sweat. So hypopigmentation, like absence of melanin will be there. Tyrosinase is a competitively inhibited by high level of phenylalanine. So next is serum phenylalanine levels, where normal level is less than 1 and benign is 4 to 10, variant will be 10 to 20, where classic phenylketonuria will be more than 20, where hyperphenylalanemia there will be more than 20. So the diagnosis and treatment, where ferric chloride test, which is older and which is less reliable, where ferric chloride will be done in urine, which is transient. It gives transient blue or green color in the presence of phenylpyruvate. Next is Guthrie's test, which is bacterial inhibition assay, where the appearance of bacterial growth around the high concentration of the phenylalanine in the blood spot. So tandem mass spectrometry will be helpful to estimate the amino acid and their products, and the enzymatic analysis also will be done. So DNA probe for parental diagnosis of phenylalanine hydroxylase and dihydrobiopterin reductase will be taken. So the treatment will be restrict the phenylalanine in the diet. So the type 2 to 5, dopa, 5-hydroxytryptophan, and carbidopa are given. Dopa, 5-hydroxytryptophan, and carbidopa will be the treatment for type 2 to type 5 phenylketonuria. Next disorder is tyrosemia, where tyrosemia type 1, which the defect is femoral acetoacetate hydrolase. So tyrosemia type 1, femoral acetoacetate hydrolase, where tyrosemia type 2, which has tyrosine transaminase, where tyrosemia type 3, which is neonatal, which is hydroxyphenylpyruvate hydroxylase enzyme will be absent. In type 1, defect in fumarate in tyrosomia type 1, there will be defect in fumarate acetoacid hydrolase, where fumarate acetoacid will get accumulates in the liver and kidney, which causes oxidative DNA damage, and it get alters to glucogenic and protein synthesis. So it causes dermatologic and neurodevelopment problems like increased tyrosine it will leads to increased tyrosine in blood and urine. So increased alternative catabolic pathway of tyrosine and dopa, which is dihydroxyphenylalanine in urine. So increased methionine and alpha fetoprotein in blood. So increased secretion of delta ALA, which is succinyl acetone derived from fumarate acetoacetate, which inhibits the heme synthesis. The alternative catabolic pathway of tyrosine in tyrosomia, so the tyrosine get alternate pathway like tyrosine transaminase. With the help of tyrosine transaminase, it goes to hydroxyphenylpyruvate, and then with the help of dehydrogenase, it forms hydroxyphenyl lactate. And tyrosine with the help of acetyl-CoA, it forms acetyl tyrosine. With the help of tyrosine decarboxylase, it forms tyramine. That tyramine get converted into hydroxyphenyl acetate with the help of tyramine oxidase and dehydrogenase. So tyrosemia type 2, type 1, where acute causes is diarrhea, vomiting, cabbage-like odor, mild, mentally retarded. Then death due to acute liver failure will be taking place. So the chronic cases where death by liver cirrhosis and generalized transport failure like Fanconi syndrome develops in PCT region of kidney, which resulting in vitamin D resistance rickets. So the treatment will be diet low in tyrosine, phenylalanine, and sometimes methionine also. So the treatment will be glutathione injection will be given. Nitrosamine, which inhibits phenylpyruvate hydroxylase, thus the accumulation of fumarate acetoacetate will be prevented. So liver transplantation is done in patient with whom nitrosamine is failed. So tyrosomia type 2, it is a deficiency of tyrosine transaminase, which is elevated level of tyrosine and alternative product of tyrosine in the blood and urine. So plasma methionine will not be elevated. So intracellular crystallization of tyrosine causes painful corneal erosion, photophobia, and keratosis of palms and soles. So mental retardation will be taking place occasionally. So the treatment will be diagnosis and treatment will be the failure of blood tyrosine to fall after vitamin C intake suggests that tyrosemia is due to tyrosine transaminase defect. So diet low in phenylalanine and tyrosine with vitamin C treats corneal and skin lesion, but not MR cannot be treated. So glutathione injection can be given here. In benign transit neonatal tyrosemia, where the defect is hydroxyphenylpyruvate hydroxylase, it is due to immaturity of the liver in premature infants. Immaturity of the liver in premature infants, where increased blood level of phenylalanine, tyrosine, and the urine level of tyrosine and hydroxyphenyl acetate will be elevated, and N-acetyl tyrosine and tyremia will be elevated. As the liver matures, the accumulation of the tyrosine is metabolized, and the serum level return to the normal in 4 to 8 weeks. So benign condition respond well to low protein diet, which is rich in ascorbic acids. So alkaptonuria. Alkaptonuria is a aromatic amino acid defect with it has a absence of the defect is absence of homogeneous oxidase enzyme. So homogeneous is excreted in urine in large amount. So the urine darkness get exposure to atmospheric air. In third or fourth decade, the generalized pigmentation of the connective tissue is a onchronosis, tissue damage, backage, and form of arthritis. So it get treated symptomatically. So the formation of alkapton bodies like homogeneous get converted into benzoquinone acetate, and then it leads to organosis. So the special product of tyrosine will be melanin, dopamine, epinephrine, norepinephrine, epinephrine, they are neurotransmitter, the role in carbohydrate metabolism, and iodine and thyroxine, tyramine and neurotransmitter. So synthesis of epinephrine. First, tyrosine, with the help of hydrolase enzyme, it get converted into dopa, and dopa decarboxylase, it get converted into dopamine. So dopamine in the present dopamine beta oxidase, it forms norepinephrine, and norepinephrine with the help of methyl transferase, phenylalanine, phenylthio, methyl transferase, it forms epinephrine. So the melanin synthesis will be tyrosine to dopa, dopaquinine, and melanin. So the absence of tyrosinase will leads to albinism. So albinism, these are the defect in tyrosinase enzyme. It is a aromatic amino acid defect. So melanin pigment which is not synthesized, symptom is photophobia, nystagmus, white hair, and skin. This is the picture of albinism. So the synthesis of thyroid hormone. So the iodination of the tyrosine residue of thyroglobulin in the follicular cells of the thyroid gland. So tyrosine on iodinization, it forms monoiodotyrosine and diiodotyrosine. Then the copulation of monoiodotyrosine and diiodotyrosine will convert it into triiodotyrosine. And the copulation of 2-diiodotyrosine forms thyroxine. Thank you so much.